Hi there, my name's Jaesh Naik and I'm a health economist with Patari Evidence. And today I'm going to be talking you through my ISPOR 2025 poster, which is titled What's Cost Got to Do with It? A review of key issues related to costs in health technology assessments in non-small cell lung cancer. So, as many of you will be aware, in England, NICE make reimbursement recommendations based on not only the clinical effectiveness of new treatments, but also the cost effectiveness. And they specifically look at cost effectiveness through cost utility analysis. And in cost utility analysis, value is essentially assessed by calculating the ratio of additional expected costs from a new treatment versus the expected additional qualities. And this outcome measure is referred to as the ISA. This ISA will generally be compared to a willingness to pay threshold of £20,000 to £30,000 per quality gained in standard single technology appraisals where no kind of severity modifier weighting is applied. And that's how cost effectiveness is determined. Now, in the right NICE reference case, it's stipulated that a payer perspective should be taken on costs. So that means that there are a range of cost categories that are included in the types of economic models that we build. So this ranges from treatment costs, so the actual cost of the drug as you'd expect, but also the cost of administering the drug, the cost of any healthcare resource use or monitoring, the cost of managing adverse events, costs of subsequent lines of therapy after the initial treatment, and also costs of care at the end of life. So there are a wide range of costs that we include in our analyses. In the NICE process, an EAG, which is an external assessment group, critically appraises each manufacturer's submission. And when they're looking at the clinical and the cost effectiveness evidence and critiquing it, they'll raise key issues that they feel are of potential importance to decision making. And although costs are a key driver of cost effectiveness outcomes, as you'd expect, they generally appear to really receive a bit less scrutiny than other aspects of the cost effectiveness analysis. So that might be things like health related quality of life or the clinical effectiveness inputs and assumptions that are informing your economic model. So what we try to do here is, using non-small cell lung cancer as a case study, is try and quantify and assess the proportion of key issues that were raised that actually relate to the costing side of cost effectiveness modelling. So really, the kind of objectives of this analysis were not just to understand how many cost related key issues there were, but try and pull out and explore common themes where in future, hopefully, additional guidance or kind of additional methods would help to kind of improve consistency and the robustness of the economic evaluations. So the way that we went about doing this was to conduct a literature review using the NICE website. So we looked for technology appraisals in non-small cell lung cancer that have been published in the last 5 years. That's generally because that was around the time when the structure of the EAG reports changed to include these explicit key issues that were either related to the decision problem, the clinical effectiveness, the cost effectiveness, or other key issues. So looking at the past 5 years, and you can see in figure 1 of the poster that there are 735 technology appraisals identified, 55 of which were related to non-small cell lung cancer. When we applied the time filter as well, the past 5 years, that was 30 technology appraisals. And then finally, when we removed any terminated technology appraisals, that left 25 completed appraisals for inclusion in our review. So across those 25 technology appraisals, we found that there were 234 key issues of potential importance to decision making that were raised by EAGs. And of these, there were 20 that were related to the decision problem, 76 that were related to the clinical effectiveness, 127 that were related to the cost effectiveness evidence, and 11 that were categorized as other. So you can see here in the pie chart in figure 2 that although the cost effectiveness key issues made up a fair proportion of the total key issues compared to the clinical effectiveness, decision problem, and other, actually the cost-related cost effectiveness key issues comprised only 15% of all the key issues. So what that means is there are essentially 28% of key issues related to cost effectiveness evidence were cost related, or as I said, only 15% of all identified key issues were categorized as cost related, which I think speaks to the kind of hypothesis I said at the start around cost potentially receiving slightly less scrutiny compared to other aspects of the cost effectiveness model when they're being critically appraised or reviewed by external reviewers. So as I mentioned, the next phase of the research not only was to kind of pull out these numbers, the number of key issues and looking at the proportions, but actually digging into these a bit more and trying to identify key themes. And I've summarized in figure 3 on the right hand side of the poster the most common themes that I kind of extracted when reviewing this wide range of key issues related to cost. The ones that kept reoccurring were the modeling of TTD, meaning time to treatment discontinuation, the modeling of subsequent therapy, both distributions and costs, and also the application of relative dose intensity and wastage when calculating drug costs. So in the context of TTD, there were quite a few key issues raised. And these kind of concerns range from the appropriateness of assumptions like assuming that TTD could be equal to PFS, the choice of parametric survival model that was applied to model TTD, the application of stopping rules, or the choice of hazard ratio used to model TTD. So even within that one category, there were quite a wide range of issues being raised. But all of these really determine or boil down to kind of trying to accurately reflect treatment acquisition and administration costs. In the context of subsequent therapy, as I mentioned, there were again quite a range of issues even within this one topic. So these range from things like the choice of subsequent treatment costs themselves, or the actual duration of subsequent treatment, appropriate sources for the distribution of subsequent therapies. So often patients receive different patients will receive different subsequent therapies, which means you might need to model a kind of basket. So what's informing that distribution? And then also the actual proportion of patients who in practice would receive subsequent therapies. And for the third point that I mentioned, the application of RDI and wastage, concerns were really raised by external reviewers around kind of unfounded assumptions around assuming differential RDIs between treatment and also not properly capturing wastage. So assuming that all missed doses or unfinished packs would actually result in fewer packs being used and cost savings for the payer, which isn't always the case. So in conclusion, I think although costs are a really important determinant of cost effectiveness outcomes, they do appear to receive slightly less scrutiny in HTA compared to other elements of the submission, based on a review of non-small cell lung cancer appraisals at least. So I think to kind of improve the consistency and robustness of economic evaluations, clearer guidance could be issued, particularly in the context of modelling time to treatment discontinuation, particularly in the absence of reported data, as is often the case for comparators, in the context of subsequent treatments, particularly within a partition survival model framework, where it can be quite hard to explicitly track patients in intermediate health states to apply subsequent treatment costs, and then also in the context of RDI and wastage. So this is hopefully an area where we can look into some further research. Thanks.